Also, our presenter today is Anne McKay, and she has her doctor of nurse practitioner. I guess that's how you say that. Hence the title on the screen. But usually, nurse practitioners in a clinical situation aren't addressed as doctor, just so you know. But they have earned a PhD, so they, from an educator standpoint, certainly are entitled to use the term because they put in the time. Believe me, it's a lot of work to get that DNP. And currently, Anne is an assistant professor at the College of Nursing at Grand Valley State. And prior to that, she spent several years practicing in women's health, and also for a time was the director of health services at Hope College. So anyway, and she now teaches at Grand Valley. She teaches NP students in geriatrics and women's health. She welcomes your questions during the presentation, but she has a hearing impairment. So please wait for the mic. I know we all get really excited to ask our questions. If you raise your hand, I'll run to you as fast as I can without tripping over things. So you can ask, so she can hear. And that also helps our audience here too. So I appreciate your kindness in doing that. And then other announcements, I guess tomorrow is our first of 2 monthly programs in April. And that kind of tripped me up. I'll tell you in a minute. So tomorrow is defining good county governance. And I think that's of great interest to a lot of us right now in Ottawa County. I want to know what it's supposed to look like. I'm pretty sure I'm not convinced I'm seeing it now, but I'm open to learning. And the presenter will be Eric Lufer. He's the president of the Citizens Research Council of Michigan, and also Allegan County Commissioner Jim Story. So we'll have, kind of an active Board of Commissioners speaking with us, as well as someone giving us a broader picture. And then I went, well, what's our second monthly meeting? Well, it's because of the Tulip Festival. The one that would be in May is on April 30th or 31st. It's the last Tuesday of the month. I don't have a calendar pulled up, but it's the gentleman who swam the English Channel. Yeah. So that's why there's 2 this month and then none in May, essentially. So anyway, we just remind people, if you want to come in person to the one over at the Jack Miller Auditorium, there will be free cookies and coffee, but you can also attend virtually online. So it's a live stream on YouTube, I believe. So, and the link is in the HASP newsletter. So with that, and without any further ado, I'll let Anne take it away. Thank you.
Can you hear me okay? Is that projecting? Great. So, well, thank you. I'm so excited to be here. I love to teach. And I was just telling Jane, because I do teach at Grand Valley, I just spent 2 full days, 8-hour days last week, teaching my doctoral NP students at Grand Valley, and it's exhausting. So now I'm with my people, you all get me. I have the same problems. So the 20, 30-year-olds, nurses and NP students at Grand Valley, they're, I like being with my people. So, and I love teaching, and I love women's health. And it's been something that's been woven through my entire 30-year nurse practitioner career. So this particular topic is a topic that I'm responsible for in the curriculum at Grand Valley. So it helps me keep up to date, even though I've not been in that practice. I do also, Jane didn't mention this, I do have a current practice. I see bone health patients at Shoreline Orthopedic part-time as well. So wanted to keep my hands in my, my toe in the water in terms of practice. And that bone health is also primarily women's health. About 3/4 of my patients that I see for osteoporosis are women. So it's exciting to be here and talk with all of you. And I need to credit Jane with this title, which I actually love. So we were brainstorming like 6 months ago, what should we call this? What should women know about the down below? It's pretty catchy. So I will tell you that, there's some, I don't have any terrible graphic pictures that I might have for my students up here. But, it's going to be a pretty frank discussion about women's health, women's anatomy, sexual type of things. So I'll give you that heads up. I also want to tell you that, you know, I pulled a lot of this presentation from presentations that I do give to my doctoral NP students. And because I put a fair amount of work and updating into this, I submitted this as an abstract, and I'll be presenting something very similar to this to the state conference of nurse practitioners in October. So I think you can actually walk out of here and maybe have some slight certification as women's health nurse practitioners by the time you get out of here. So you can inform all of your friends. So my objectives today, I always have to have objectives, right? Just talk about what are expected age-related changes in the genital urinary system. What should you expect? What's normal? What's not normal? We're going to talk about some modalities or strategies to improve your GU health. I'm going to talk about some vocabulary and strategy for discussing your GU health with your provider. And I think that's actually probably one of the more important parts of this talk. And then I'm going to give you some local and national resources to look at. So for many years, what I'm talking about was called atopic or atrophic vaginitis or vulvovaginal atrophy. That was the title that we used for these symptoms that women have related to this system. In 2014, the North American Menopause Society changed that terminology to genital urinary syndrome of menopause. And I think syndrome much better captures this because this goes well beyond, dry vaginal tissues. So we really want to encapsulate everything that's happening to a woman because this also involves the urinary tract. So now we use the terminology GSM as for abbreviation to be helpful. And this is a chronic progressive disease. This is not something, and I don't like to use condition is a better word. I don't like to use the word disease, but it's a condition that comes naturally out of the progression of loss of estrogen, and I'll talk about that. And the North American Menopause Society, a lot of what I'm talking about comes out of their 2020 guidelines. And they're reporting that 27 to 84% of postmenopausal women will report some degree of GSM symptoms. Now, why is that such a wide range? That's a big range for reporting. It comes out of the fact that they're looking at a kind of a systematic review of the literature, and some studies report it less than others, and that probably has to do with who did they interview, how many people, what questions did they ask. But I will tell you, it is very prevalent in postmenopausal women to have some degree of GSM. In 2013, Simon, one of the authors of this study, did a survey of several hundred women, the Vaginal Health Insights, Views, and Attitudes Survey. So just to talk about what the impact is on women's lives if they have GSM symptoms, there's 80% report some type of negative impact. This is impacting me negatively in my quality of life. It has adverse effects on sexual intimacy, on relationship with their partners, women feeling less sexual, feeling older, impacting their self-esteem. So it goes well beyond the fact that they've got urinary frequency or vaginal burning or that type of thing. It pretty encompasses, their life and their quality of life. And this study was done, now 14 years ago. I'm not sure that if we did this again, we'd see a big improvement because there's been advances in things that we can do to treat GSM for sure. And I'll talk about some of those. But if it's not treated, it's still going to have this negative effect. And one of the things that's discouraging, and these are from the 2020 NAMS report, only 50% of US women who have these symptoms actually get treated for it. So there's not a high level of treatment. So you can imagine if only 50% were being treated for their diabetes or their hypertension, we'd have a pretty big health crisis on our hands. And one of the reasons for this is only 25% of women will actually go in and talk with their providers about it. And I'll talk a little bit more about that in a few minutes and maybe give some strategies for talking to your provider if this is an issue. So I really hope we'll come out of this talk. You'll come out of this talk if this is an issue, feeling more empowered and enabled to advocate for yourself. So it's really all about the estrogen, and I don't think that's a surprise to any woman in this room whatsoever. So we know that estrogen peaks in the 30s and 40s, and then it's got a slow decline. And estrogen affects more than the GU system. There's brain changes with lack of estrogen. If any of you recall that kind of fogginess that you may have, increased depression. So there's brain effects. My other specialty is bone health. That's certainly why we see more women with bone health issues. With that decline in their estrogen also leads to osteoporosis. So estrogen is kind of key to the whole story here. And you can find your age group in there and you can find out where you are in terms of your estrogen. But it's not just older women who have problems with estrogen deficiency. So you may have daughters or nieces or, younger people in your life who have, for whatever reason, had to have a total hysterectomy and their ovaries removed. There's a number of reasons that might happen. Um, they're going into surgical menopause at earlier ages. And the problem with that is the younger you are, uh, the more symptoms you're going to have with that. And also the lower your body mass index, because you may know that adipose tissue is an organ in of itself. Adipose tissue produces estrogen. So if you ever wondered why you had such a flat belly at 40 and you got the roll at 50, that's because your body is going, let's make a little adipose tissue so we can produce a little estrogen so we can make up for your estrogen deficiency. Totally unfair, totally unfair. But it actually is your body trying to compensate for that. So when we pull estrogen for younger women and they have low BMIs, they are very estrogen deficient. And then, of course, breast cancer survivors who are on these drugs called aromatase inhibitors, which basically prevent any estrogen production, endogenous internal estrogen production in their bodies. So you may know some younger women coming up behind you that are dealing with these symptoms. I will say, I feel like oncology is getting better and better about treating this because I've seen that through my career. But I brought it up because I want you to know, there's other people besides postmenopausal women dealing with this. So again, decreased estrogen, atrophy of the tissues, loss of tissue integrity, those rugae, the vaginal wall, those nice, folded things that give elasticity, they go away. There's a narrowing of the opening of the vaginal opening or the introitus. This can become really problematic if at some point we really need to do a speculum exam, to do an internal exam. I'll talk a little bit about that. And then there's actually a shortening. So everything kind of gets a little drier, smaller, less elastic. And there's a really graphic kind of depiction for you of what happens with these tissues when the estrogen goes away. So what's the solution for this? Well, you naturally might think it's estrogen, and it is, and the gold standard. Well, let me talk more about effects of estrogen deficiency. So on the genital tract, dryness, burning, irritation, which then can lead to pain with intercourse. There's this, we talk about friability of tissue, which just basically means that tissue is very fragile. It bleeds easily. It can cause abnormal genital bleeding. Then that becomes a problem because if you're starting to spot, then we need to know, is that blood coming from the vaginal tissue because it's so fragile, or the vulvar tissue because it's fragile, or is that bleeding, if you still have a uterus, is that bleeding coming from your uterus? any postmenopausal woman who's spotting, we need to know if you have a uterus, if that bleeding is coming from their uterus. That is a do not pass go. Get to your gynecologist. We need to know if you have endometrial cancer or lining of the uterus cancer. So, it complicates the picture because you've got this dry vaginal tissue that may be bleeding, but it's going to lead you down the road to have a much more invasive evaluation of that. So, and then we forget that these tissues are really close together. And I'll show you at the end of this talk, I'm going to talk more about urinary tract issues. We forget those tissues are all part of the same area, all estrogen dependent. So we get these changes in the urinary tract. So we can get pain with urination. This is aside from any type of infection process. So we can get pain with urination, urgency, frequency. Again, blood in the urine from the friability of the urethral tissue, and then increased bacteria in the urine because it changes the whole milieu of the genital, of the urinary tract system. So, that estrogen is really important. The lack of estrogen also increases the vaginal pH. A normal vaginal pH is 3.8 to 5. Your normal body pH is 7. So vaginal pH is already a little bit acidic. But when that estrogen goes away, it makes the vaginal tissue, vaginal milieu less acidic. And therefore you lose these lactobacillus, which are these really healthy bacteria that are in the genital urinary tract that are protecting you against infections. So that environment becomes less protective and there's an increased risk for bacterial and fungal infections. So, you can kind of see it starts to pile on, right? The estrogen's not there, and then we have all these tissue changes, and we have the changes in the bacterial milieu or environment. So in talking about treatment, we want to talk about individualized goals of treatment. And the first thing we're going to want to do as your physician, your nurse practitioner, you yourself, we're going to make sure we exclude other causes for these symptoms. And I'll talk about that in a minute. Secondly, we want to alleviate your symptoms. And part of that is knowing what symptoms are really bothering you. And third, we want to make sure that this treatment is safe, effective, acceptable, and I probably need to add affordable to that. So anybody who's involved in buying medicine these days realizes that that's an issue. So differential diagnosis, in other words, you have vaginal burning, you have vulvar dryness, you have bleeding. Of any of these symptoms that are related to GSM, we should never go. It's very easy to say you're postmenopausal female, you have that estrogen deficiency, so it's just GSM. We should never go from the point A to point C without looking at point B in between. Are there other things that are going on that may be the cause of your symptoms? And there's a number of opportunities for other things to be going on. Allergic or inflammatory conditions, psoriasis, vulvar psoriasis is something that can mimic this. And I'll talk about some other vulvar conditions later on. So allergic, are you suddenly allergic to your laundry soap? That's a common one. Again, I mentioned that you're more prone to infections like bacterial vaginitis or yeast infections, candidiasis. And you may laugh at the sexually transmitted thing, but over the last decade, there's been a big bump up in sexually transmitted diseases in the 60 to 70 and above 70 group. So it should not be, depending on lifestyle type thing, that should not necessarily be taken off the table. Malignancy, I mentioned endometrial cancer, systemic disease like diabetes can increase your risk of some of these vaginal infections, lupus. Vulvodynia is a 3-hour talk in and of itself, and then it's pain of the vulva, and it's very complicated, trauma, foreign body. So just to give you an idea that there are a lot of other things that could be contributing to these symptoms or causing these symptoms alongside or instead of the GSM. So what type of things should impact treatment? Now I'm kind of talking from my clinical side of things. What kind of things do we need to look at? Well, first of all, the age and general health of the woman who's experiencing these symptoms. Comorbidities. Does she have other disease processes? Does she have diabetes? Is she on medications like aromatase inhibitors that might be impacting this? So you have to look at the whole person, not just their age, but what other medical conditions or medications might they be on? What symptoms are most bothersome to the patient? I can't tell you how many times I've done a pelvic exam and seen very, very atrophic, dry, fragile vaginal tissue. And it's really not bothering the patient. So I might be like, oh, you really need to treat this. But that may not be what's bothering her. Maybe what's bothering her is that the urinary frequency, and she's getting up during the night to urinate all night. And some of that is related to her estrogen deficiency of the urinary tract. You want to know what's the impact on the quality of life. I've already mentioned it can have a big impact on sexual quality of life and general quality of life. Are there additional menopause symptoms? Are women having hot flashes? Are they having some of the mental status changes or some of the other things that go along with early menopause? And I'm going to talk a little bit about hormone replacement therapy down the line when it comes to this. Convenience and acceptability. Is it acceptable? Can the patient actually carry out this treatment? Can the patient afford the treatment? And then are there reasons a patient shouldn't be on treatment? Are we going to put somebody with breast cancer on estrogen? No, we're not. So that would be a very obvious one. So there are a lot of things to look at. And I'm telling you these things because when we talk about going into your provider to talk about these things, they need time and information to work through this type of discussion with you. So we always take a step care approach, just like when people are managing when your provider, your physician is managing your blood pressure. We'll start here. That doesn't work, we'll add this. So we want to start simplest, cheapest, least side effects, and work our way up. And by reassessing and adding treatment as we need it. So if the primary concern is vaginal, particularly sexual, because it's interfering with sexual health, we can start with strategies just to increase lubrication and elasticity of the vaginal tissue. So over-the-counter lubricants are generally safe and effective. But again, at the bottom of the slide, you'll see a web address where you can actually look up lists of lubricants that will give you some of this information. But you want to be careful that you don't further change the pH of the vaginal tissue. And also you don't want this to have a high, now I basically flunked organic chemistry in nursing school, but the high osmolality, which is actually going to pull fluid out of the tissue rather than put it in. So it can also decrease the lactobacilli, so increasing vaginal infections. So you want to kind of maintain a normal pH, and you don't want a lot of additives in these, scents and colors and anything else besides just something that's lubricating. So KY jelly is the most common one you'll find on the market. And actually, it probably really falls closest to a lot of these requirements. But if you want to know a little bit more about this, womensvoices.org will give you a list, extensive list of the characteristics of lubricants. Vaginal dilation is something that is often carried out by pelvic floor physical therapists, by women's health providers who are more specialized in menopause. Not all OBGYNs would be prescribing this, and also oncologists who are dealing with women on aromatase inhibitors. And basically that's just progressive dilation, actual dilators, the vaginal opening and tissue, that women progress through these dilators. So they're gradually causing some dilation of the opening of the vaginal opening, the introitus, and the vaginal tissue itself, usually done in conjunction with vaginal estrogen so that you can restore that tissue. That I have had in my women's health experience, women who have not been on estrogen, who have severe GSM, who actually the vaginal introitus or opening just becomes so narrow, so stenotic or stiff that you cannot introduce a speculum. That is problematic if we ever really need to do a true speculum exam. If the patient is starting to bleed, how are we going to look and find the cervical opening to do an endometrial biopsy or other testing? So that's something we want to avoid, no matter how old the woman is. I don't care if you're 80, we want to maintain the integrity of that vaginal opening or that introitus. So it's just something that I've run into in clinical practice, and my colleagues, my obstetrician gynecology physician colleagues have run into, and it can be problematic. So now I'll get to the vaginal estrogen. So the NAMS, North American Menopause Society guideline, vaginal estrogen is the gold standard for treatment of GSM. And there's lots of options that we can use. The reason it's the gold standard is because you're delivering estrogen directly to the tissues that actually need the estrogen. And you're not delivering it to the whole system. And we'll talk a little bit about that. So minimal systemic absorption, better safety profile, fewer side effects. It positively impacts the genital tract, but also positively impacts the urinary tract. And I think that's important, that you know that it's treating both systems. And then we have a variety of delivery methods, because again, we go back to what's acceptable, what's affordable, what can a patient actually reasonably incorporate into their lifestyle. So Estrace cream is the brand name we most often use. This is estradiol, form of estrogen. And this is a cream that can be used externally as well as internally with this nice little applicator. And usually if a patient has pretty significant GSM atrophic changes of the vaginal vulvar area, we're going to do this nightly for 1 to 2 weeks at a little higher dose, and then back off that dose to maybe 1 to 3 times a week as a maintenance dose. If you start this and stop it, eventually the benefits will go away. So this is something that you're going to have some maintenance with. What's the problem with it? It's a cream, but it liquefies. So then there's some vaginal discharge. Anything that you introduce can cause irritation. You may just not tolerate it. And 10 years ago, this medication was cheap, and now it's like $100 a month, and I cannot figure that out. I'm just like, it used to be I write these scripts, and I also practice women's health at City on a Hill in Zealand, which is a free clinic for women. And I was so shocked a few years ago when I was like, oh, this will be fine. This is going to cost you $20. And the patient called the clinic the next day and said, this was $120. Well, if you're going to a free clinic, I'm not paying $120 for this, but these are obviously patients with no insurance either. And so I'm like, why is this so expensive? So don't get me started on prescription costs, but it can be expensive. Vaginal suppositories, the most common one that we've used for a long time, are called Vagifem. Put the little tablet in the dispenser, insert it, push the little plunger. Tablet sits in the vaginal vault. Can cause a little bit of discharge, but nothing like the creams that I was talking about. There's a new latest and greatest vaginal estrogen soft gel called Invexi that's been out for a few years. Again, I don't know what the cost of this is. That all these drugs are indicated for GSM symptoms. Invexi specifically says dyspareunia, which is painful intercourse. So I think they're marketing to that if you're sexually active and you're having painful intercourse, that they're saying that this might, it's related to vulvar vaginal atrophy, but they're saying this may be a more effective drug. And I'm sorry that I did not try to look up the cost for this. I meant to, and I didn't. So, this is my favorite thing to prescribe if it's acceptable to women, and those are vaginal estrogen rings. So back in the day, if any of you had a diaphragm and you were familiar with sliding that diaphragm in and getting into place, this is a lot easier than that. Basically, it's a silicone ring that can be compressed, inserted in the vagina, pushed in with the finger, and that ring sits there and can be present for 3 months. Doesn't get in the way of anything, doesn't get in the way of intercourse. Women don't feel it. I think the issue that I've had with some women is going to retrieve that ring and actually having to reach in, hook that ring and pull it out. So you have to have some manual dexterity. You have to have some comfortable, you have to be comfortable with doing that yourself. So I have had patients in my practice that we have put them in and taken them out for them, come in for an appointment, and we'll actually, take forceps and speculum forceps and remove them. But it's a very nice option to have this ongoing estrogen delivery that you don't have to think about. It's just there and it's very effective. But this little point that I'm about to talk about is something that I pound into my nurse practitioner students, because there are two types of vaginal estrogen rings. There's the S ring, which is delivering vaginal estrogen. There is the fem ring, which delivers so much estrogen that it also is giving you systemic estrogen. So then you're finding estrogen circulating in the bloodstream. And with that, we need to be careful because we want to make sure that we're not giving estrogen, systemic estrogen, to a patient who shouldn't have it. Let's say breast cancer, or they have a history of blood clots, or they have a contraindication or reason they shouldn't be on systemic estrogen. So this is a question on every nurse practitioner test, is like, don't mix up these two drugs because there are implications for doing that. Now, if a patient is having hot flashes, having night sweats, having vaginal GSM issues, and they don't have a uterus, I'll talk about that in a minute, so that they can have just estrogen without progesterone. This is a really nice choice because we can treat their hot flashes, we can treat their vaginal issues in a safe way, but we can't just give estrogen to a woman with a uterus. And I'll talk a little bit more about that. And tell me if I confuse you on this. You're welcome to ask questions on this. Have any of you heard of vaginal DHEA? This is something that this has been around for a while as orally. And so back in the day when I first started in OBGYN, some of the older physicians would prescribe DHE orally for sexual dysfunction, for GSM symptoms. I'm going to talk about the fact that we've decided that's probably not the safest thing to do, but vaginal DHEA is very similar to estrogen. It's kind of a precursor to hormones. So when it's introduced to the body, your body will convert this to estrogen and testosterone in the vaginal tissues. The brand name is Interosa. So again, these are like little inserts, and they're approved for the treatment of moderate to severe painful intercourse. So you can get some discharge from this. Studies show that there's little or no effect on the lining of the uterus. So that's just saying if you have a uterus, we don't have to worry about you using this drug. But there aren't a lot of studies on this drug. So it is used in practice, but not nearly as much as the gold standard of estrogen. But I bring it up because you will find it on lots of websites. So if you get out there into the internet world and you start searching, you may see information about DHEA. I want you to be familiar with it, to know that vaginal DHEA, to the best of our knowledge in small studies, is safe. And also they're talking about there may be some improvement in overactive bladder symptoms, again, because it impacts both systems. But I want you to know that you should avoid oral DHEA. So again, this was a big thing in, I think, mostly the early 90s, where there was all this press about DHEA for weight loss, slowing your aging, improving your cognitive function, improving your sexual desire. But it does increase the effect of estrogen. So it has an estrogenic effect, systemic effect. So if you're a person who shouldn't be on estrogen, you don't want to be on DHEA. It interacts with lots of medications, particularly anti-seizure and antipsychotic medicines. So you wouldn't want anybody who is on meds to prevent seizures on this. And it can also increase your bad cholesterol and some vascular problems, in part because then it starts acting like testosterone in your body. So if you get caught up in seeing some of these things about this wonder drug DHEA, and I looked for it and you can still find it on the internet, you don't want to go down the DHE oral medication path. So again, with all of these interventions, all of these medications, you know, me and Priority Health are not always good friends. When I'm trying to get things approved for my bone health patients, for sure. So not insurances don't cover all the medications or don't approve all the medications I've been talking about. The cost varies by the pharmacy. Obviously, it varies by your insurance and your copay. It can be expensive and it's dependent on the dose and frequency. So then, you and your provider need to weigh out the risk benefit cost of this in terms of treatment. And I think that should always be part of the conversation. I think too often, we write these scripts and have a nice life. Here's your script. Well, we don't write scripts anymore. We just send them to the pharmacy. But you get to the pharmacy and then, you're having heart palpitations when they tell you what this is going to cost. So I think it's very important that that's part of the discussion. You have some idea what this is going to cost you. So now I'm going to talk more about that estrogen safety type of thing. We should never be giving estrogen to women who have undiagnosed genital bleeding. So they may have endometrial cancer. So remember what I said, you're postmenopausal, you have a uterus, you're spotting, do not pass go to your gynecologist. You need an endometrial biopsy to make sure that's not cancer. So, and if you're on estrogen, you're going to stop it and you're going to go talk with your provider. So, and there's also a warning that those patients who have undiagnosed genital bleeding should avoid vaginal estrogen as well. We want to use the lowest possible dose. That's why I said, you start high and then kind of go down to a maintenance dose. Use for as long as you need it. But if you pull these estrogens, eventually the symptoms will come back because it's really the estrogen is treating the estrogen deficiency. That estrogen deficiency is not going to be fixed by it. You're just providing the estrogen. When you pull that estrogen, those symptoms will gradually come back. And women who have a uterus, if we put them on oral or systemic estrogen or oral DHE, as I mentioned, they also have to be on progesterone. I think I have another slide on that, and I'll explain that a little bit better. But if you look at estrogen preparations, vaginal estrogen preparations, you will find a package warning that says these products give you a risk for endometrial cancer, breast cancer, cardiovascular disorders, probable dementia, equal to systemic estrogen. But the data doesn't support that. And so I always need to talk to patients about this. So this is true in my bone health world as well, because drugs like Fosamax that were used for a long time on patients without monitoring cause some unusual things like atypical femur fractures, osteonecrosis of the jaw. But that warning has now been put on every single osteoporosis drug, whether there's data to back that up or not. So this is just the FDA trying to protect you, but you need to know that low dose vaginal estrogen does not raise estrogen blood levels above your typical menopausal. So it's considered a safe thing. But you read the package insert. How many times do we read the package insert and go, I'm never taking this drug. If you read the package insert for any drug you're taking, you would never take it, just the side effect list. So just a word about that. If you need vaginal estrogen, whether you have a uterus or not, as long as you don't have active breast cancer, and then again, there's some controversy about risk for breast cancer, but as long as you don't have undiagnosed, genital cancers, genital bleeding, this is considered safe. So let me talk about the one oral medication that's available for GSM, and that's Ospina or Ospemifene. And this is an oral medication that's probably been out for maybe 10 years now. This is a drug that acts like estrogen in the urogenital tract, and acts like anti-estrogen in the breast. Evista is another drug that you may be familiar with that is sometimes used in patients at risk for breast cancer. So basically, it can restore and treat GSM. And also there's some evidence that it can lower your risk for breast cancer. So the bad part about it is it can act like estrogen and increase your risk of endometrial cancer, blood clots, and strokes. So I do know that some more background data on this, that it seems to be a very safe drug and it's been widely used. So I'm telling you what the package insert is saying, but it's nice to have an oral medication that's effective. So when is hormone replacement therapy? Hormone replacement therapy, that by this I mean you're taking oral medication or you have a topical patch that's delivering estrogen and that's delivering estrogen and progesterone. When significant vasomotor symptoms, meaning hot flashes, night sweats, are present, vaginal estrogen is not going to fix those. But we need to talk about, when do we use HRT? We don't start HRT when you're 60 years old, because the risks far outweigh the benefits at that point. So if you're going to use hormone replacement therapy on a patient with estrogen or estrogen and progesterone, if they have a uterus, you want to do that at a younger age, maybe the perimenopausal age or the early menopause. You may still be having hot flashes at 80. There was that whole thing about how we would tell patients, you're gonna outgrow this, it's gonna go away. Not necessarily. So it's very appropriate to start this on healthy young women. We would not want to start this on you if you're having hot flashes after the age of 60. Vasomotor symptoms tend to improve over time, but GSM tends to get worse. So women without a uterus, women without a uterus can have estrogen only. Women with a uterus need estrogen and progesterone. I'm not going to go deep into this HRT thing because it's not the purpose of this talk. But you do want to be careful that you don't find yourself, if you have a uterus, you don't find yourself on estrogen, oral DHE, or some of these compounded drugs that have estrogen in it. So you can get compounded medications that you don't know the content of it. So a couple more alternative therapies. Hyaluronic acid is considered a vaginal moisturizer. This is the same thing that the orthopedic surgeons are injecting in your knee to fix your cartilage. But it can be used as a vaginal moisturizer, and small studies show that it's effective as a lubricant. The suppositories are called Reverie, and they're FDA approved, and the gel is called Prilofem. I've never actually prescribed this or used this, but I bring it up because it is in the NAMS, North American Menopause Society options. And then herbs and phytoestrogens. Phytoestrogens are just plant-based materials that will deliver estrogen. So things like black cohosh, red clover, chase treeberry, dongguai, uh, evening primrose. You can see the list here. It's really starting from the most potent, probably to the least potent there, and soy byproducts. These medications or these herbs are not going to fix your GSM. So they're not helpful for that. They do have some efficacy for vasomotor symptoms like hot flashes, not nearly as effective as estrogen. So, but you do have to be careful because they can have a strong estrogen effect. So if there's breast cancer or high risk for breast cancer, you may want to consider that. You want to be cautious. So this doesn't mean that you can't have your cup of soy milk, in the morning and suddenly you're going to end up with breast cancer. We're talking about very concentrated sources of these herbs and phytoestrogens, which are marketed. So, but they're not going to help your GSM. And then finally, there's these energy-based devices, and this is a trending alternative treatment. Often it's advertised as vaginal rejuvenation, which kind of makes me laugh. Vaginal tightening, it's a very cosmetic type of wording. They're not FDA approved for GSM treatment. There is some evidence for efficacy, but there haven't been big studies. This is not endorsed by either the American College of Obstetrics and Gynecology or NAMS, and they can have some side effects. Interestingly enough, I'm going to talk to you about the current menopause provider at Holland Hospital for women's specialty services, and they do offer these services in that clinic. However, they're not covered by insurance. They're self-pay because there's not enough. They're not FDA approved for what they're doing. So it's hard for me to think that the providers at women's specialty service would offer something that they felt was really harmful, but I'm not really sure how much evidence is behind actually using these. If it was me, I'd think, what do we have the most experience with? What do we have the most evidence of? What do we have the safest thing? And go back to vaginal estrogen. So let's talk a little bit about vulvar conditions. The most common one we see is lichen sclerosus. It's about 25% of women who present with vulvar irritation have lichen sclerosus, and this will cause them to seek care. This can be asymptomatic, and that's problematic if you don't know you have it. We'll talk a little bit about that. These are white plaques, kind of raised plaques on the skin, and then the tissue, the women sometimes know about it just by touching it. And the texture of the skin changes. It feels very kind of parchmenty. So they may know that they have it if they haven't actually looked or had someone notice it. So, and it's usually like in the vulvar opening is kind of like a figure 8 pattern. It's a classic pattern for it. And as I said, it can cause a lot of discomfort, but it can also be asymptomatic. The reason we want to know about this and not miss it is 4 or 5% of these lesions can progress to squamous cell cancer. So we want to find this in women and treat it. Vulvar cancers, we talk about VIN, vulvar intraepithelial neoplasias. These are squamous cell lesions of the vulva that can progress to true squamous cell cancer. In younger women, it's almost always associated with human papillomavirus. In older women, it's almost always associated with undiagnosed, untreated lichen sclerosus. By the way, lichen sclerosus is treated with high-dose steroids. So it's, typically they'll do a biopsy, but it's a very treatable condition. So melanoma. You may not think you could have a melanoma lesion on the vulvar, but on the vulva, but you can. And I lost a healthcare friend, a fellow nurse, about 25 years ago from vulvar melanoma that didn't get noticed. It progressed to systemic disease and she died in her late 30s. So that's always been something that I've been very adamant when I've been doing exams to actually really look for. And Paget's disease, you may have heard of Paget's disease of the bone, Paget's disease of the breast. There's also Paget's disease of the vulva. And about 10 to 20% of women with vulvar Paget's disease have an underlying adenoma carcinoma. So just to let you know that these cancers are there. And as I talk about getting an exam, this is the reason we want to be aware of symptoms that we're having and seek help for it and seek someone who really knows what they're looking for and looking at. So these symptoms can be itching, bleeding, discharge, very general symptoms that can also be related to just straight GSM. So general lifestyle things, you all know this. I don't think I need to tell you, don't douche, avoid feminine hygiene products, sprays, that type of thing. Avoid harsh soaps, holistic diet, that type of thing. I think that's something that we don't get to this age without having heard some of this in our lifetime and following through with this. So let's talk about barriers to GSM care. And those barriers are on both sides, on the provider side and on the patient side. So on the provider side, so I have experience on both sides, right? On the provider side, there is, and all of these things that I'm listing here, these 5 things are kind of interwoven. And a lot of it now comes out of the fact that your providers do not have a lot of time to provide care for you. Have you noticed that? Have you noticed that you used to sit down and talk to your GP and they'd ask how the kids were and blah, blah, blah. And now you're like in, out, check the box, we're out the door. That's because that's being mandated by large healthcare systems. I have nurse practitioner students that I go into clinical with, and they're mandated to see 24 patients a day. You cannot provide good care when you're seeing 24 patients a day. And I don't even know what the physician's quotas are. Those are the nurse practitioner quotas. I'm guessing the physician quotas are higher than that. So they have a lot of time constraints. So they may not provide you with a safe place to talk about this. There's data that says when a patient starts to talk, the average time before they're interrupted by a provider is 16 seconds. So I come in and say, well, how are you doing today? What'd you come for? What can I do for you today? And you open your mouth and you have about 16 seconds to tell me, and then I'm going to tell you what we're going to do about it. We try to teach I try to teach my nurse practitioner students not to do that, but it's part of that time constraint. And it also doesn't provide you a really safe place to talk about things, right? It's hard enough to talk about your ingrown toenail. Now you're going to talk about, I have this vulvar problem. They're not, if they're giving you 16 seconds, it's difficult to have a safe place. So I want you to know that they have constraints on their side that they're acting out of, not because they don't want to provide you with really good care. And I'd say that about physicians and nurse practitioners. The other part of it is if you're talking to a general practitioner, internal medicine, they have to know a lot about everything. And so they may not know all of the things that I just told you about women's health options. They may not have all those options at their fingertips. And when we don't have options at our fingertips and we don't have answers to the patient, we tend to ignore what they're saying because we don't have good answers for that. So let's just talk about your diabetes. And I'm being very 30 years as a provider, I can tell you this is kind of what goes through some of our heads sometimes. If we don't have the answers, we may not be asking the questions, right? On the patient side, you have to know what's normal and not abnormal. So, vaginal pain, itching, burning is a physiological response to your lack of estrogen, but it's not something you need to live with. So really making a distinction about what it should be and what it could be. Or you think that this dysfunction is just inevitable, I just have to live with it. I see that in my bone health practice because grandma fractured, mom fractured. Of course I'm going to fracture. So there's not that motivation to get it treated. You may have a not, patients have a lack of knowledge regarding treatment options. Hopefully you have much more ammunition now, sorry, much more ammunition. Um, Fears related to treatment. We've heard such bad things about estrogen, that maybe we don't want to go down that path. Not really having the vocabulary. And then that's probably not true for the women in this room. But what if you're from a different culture? Or what if English is your second language? Those are the patients that I see at City on a Hill that they can't even tell you what the problem is. And then I think embarrassment. We just might not necessarily want to go into our provider and talk about all these things. So some strategies, you really do in this day and age have to advocate for yourself. Don't wait for your provider, physician or nurse practitioner to ask you what the problem is. You have to advocate for yourself. I say this also to my bone health patients. If you're going to go to your provider, you need to make a separate appointment to talk about your osteoporosis. I would say the same with this. Don't try to lump this into your annual exam, or don't try to lump this into your, we're going to check your diabetes and oh, by the way, it's an important issue. It's important for you. It's important that you get appropriate care. I just told you all the things that should be considered, when a provider sees a woman and they're trying to get a history and they're trying to figure out what's the best thing. So if it's important to you, make a separate appointment. It might be your $25 copay, but it'll be worth it. And then have some description of the problem. So again, providers have very little time. And so before you go into your visit, think about what is really bothering me. When did it start? How long has it been going on? What have I done to fix it, if anything? And what's been the result of that? That's the history that we teach nurse practitioners to take from patients. If you come in and you spoon feed it to them, they will be so happy. They'll be like, oh, it started here. This is how long it's been. It's getting more severe. And you give them what's really important, that information so they can act on it. You can use a universal pain, I should say scale, not scan. You can use a universal pain scale as to how painful this is or how bothersome it is, and let them know the impact on your life. So you really do have to go in there with your script about what's wrong, so that you can convey that. The other thing is when you call to make an appointment, we pull up our computers in the morning and we see the patient's name and we see what's called the chief complaint. So what is this patient coming for? Well, I will tell you about a third of the time, whatever it is they said has nothing to do with the chief complaint is, which is confusing. But if your chief complaint is vulvar pain, that prepares that provider to walk into the room and know what this conversation is going to be back. So don't be vague when you call about about what you're there for. I think it's really important that you know these kind of strategies in dealing with your provider. So the other issue we have as we get older is we don't need to have pap smears anymore, right? 30 to 65, it should be every 3 to 5 years. And that relates to whether you get human papillomavirus testing or whether you've had previous problems or not. After 65, cervical cancer screening is no longer recommended. So then what happens? So you go for your annual exam and nobody's looking below your belly button, right? And it's interesting that there's no, so I looked at the NAMS guidelines, I looked at the ACOG, American College of Obstetric Gynecology guidelines. There's no evidence against or in support of screening pelvic exams for STIs and cancers or other vaginal infections like just bacterial vaginosis, which is not STI, in asymptomatic women. So we don't have a lot of guidance. There's no like evidence we should, evidence we shouldn't. it really becomes a conversation between the woman and her provider as to whether you want to do this exam. The advantages of this exam is that there should be somebody doing a vulvar examination, and it's nice to have a professional do it. As uncomfortable it is, because I just told you some of the things that could be vulvar issues that you yourself may not notice, or your partner may not notice. If you have a partner, if you don't have a partner, then you may not be doing that self-exam. Sometimes if you have a dermatological exam, the dermatologist will look. Now, my dermatologist graduated 2 years before my older son from Howling Christian. I'm not going there with him. You can look at my scalp, you can look anywhere. I'm keeping my underwear on. Okay. But my daughter just told me, she's a nurse practitioner at Northwestern in Chicago. She has a family history through my husband of melanoma, and she's worried about it because it's a strong family history. She went to her dermatologist at Northwestern, female dermatologist, put her right up in the stirrups. I'm going to take a look at this because I need to take a look. So, I put that out to you that it's uncomfortable, but, there can be asymptomatic symptoms that it might be nice to have somebody do that exam and let you know. So, pelvic exam with close internal externals is appropriate in the standard of care if you're coming in with those complaints. So before I was just talking about screening, right? What I just said was about screening. You don't have any symptoms, but somebody should be looking, right? Now I'm talking about, you actually come in with symptoms. Shouldn't be making a diagnosis of GSM based on just your description of symptoms, because I just gave you all these other differential diagnoses that this could be. So it really needs a true evaluation. And sometimes they'll do a wet mount, take a vaginal sample and look for bacteria, look for white blood cells, may do a urine. And then I mentioned that sometimes a speculum exam is not feasible if there's severe GSM. If you're discussing treatment options with your provider, make sure you have a general idea of what you think is feasible and acceptable to you. Like maybe that vaginal ring is not going to be acceptable to you because you're not going to be comfortable putting it in or taking it out. So go in with your list of questions. Understand that therapies do take time. Some of these therapies take up to 3 months, and sometimes it's a trial and error. So you're going on a journey to try to fix this. So I'm going to switch over to a little bit of the urinary tract, and I have a couple more minutes. I'll be done, and then we have some time for questions. So I mentioned that the urinary tract is obviously part of this syndrome, genital urinary syndrome of menopause. You can see here that vaginal tissue and that urethra are just separated, probably some muscle fascia, but they're very close, and they're actually generated from the same kind of embryonic tissue in formation. So in human development. So urinary tract symptoms that you can have. Now I'm talking simply about related to GSM. I'm not talking about urinary tract infections per se right now. So you can have dysuria or pain with urination because of lack of estrogen, frequency, urgency, nocturia. You can have overactive bladder, which is something else, but stress incontinence is a big thing related to lack of estrogen in the system. And that's kind of that sudden leaking that you get from intra-abdominal pressure. You cough, you sneeze, you pee. Sound familiar? And then there can be increase in urinary tract infections. So 40% of postmenopausal, PMS postmenopausal women have urinary incontinence, and it's really related to pelvic floor weakness that's worsened by estrogen deficiency. Now, if you've had a few babies, that's going to affect your pelvic floor strength as well. But when that estrogen goes away, you also, again, lose that integrity, lose that tissue, lose that strength. And you can get some real structural changes where that bladder, well, you can get uterine prolapse, You can also get bladder prolapse, or that bladder. I'll show you a picture in a second. And the women who are greatest risk for this are if you're obese and you have that kind of that body weight that's contributing to this. So this is kind of what it looks like. If you look on your left, you're going to see, there's that nice bladder. There's a sphincter between the bladder and the urethra as it exits the body. There's the vaginal vault with the uterus. Everything's where it should be. A cystocele is the technical term for when that bladder drops, and see it impinging on the vaginal wall. And then all of a sudden that bladder's dropped down there. There's changes in the opening from the bladder to the urethra. And you can see you don't have, that urethra's sphincter is not working as well to stop the urine flow. You're getting pressure onto the vaginal wall. And then when we do a bimanual exam, and we're bimanual, meaning we have one hand on top and one hand on the bottom, when we're reaching in, that bladder is just, we can feel it. It's pushing right against that vaginal wall. And that really contributes to stress incontinence. So what I'm not going to do right now is talk about all the surgeries that you could have related to this. It's beyond my beyond my scope of practice and beyond my expertise. But I am going to talk about vaginal estrogen and stress incontinence, because there have been a number of studies, small studies, that demonstrate improvement in stress incontinence with vaginal estrogen. So pretty simple first pass thing to try. You need 3 months of therapy for it to be effective. Pelvic floor PT, which I'm about to talk about, is more effective than vaginal estrogen alone. The most effective is if you have vaginal estrogen and pelvic floor PT. So again, these are things that we're trying to do to keep you from having to go to have surgery and mesh inserted. And there's been a lot of problems with some of those surgeries over the years. So lifestyle modifications would include weight loss, time voiding. So, we're gonna may have a schedule that we're going to be in the bathroom every 3 hours and attempt to void, and then scheduling our fluid intake. So you probably many of you already don't drink a lot of water at night, because you know that you're going to be up at 2:30 in the morning, and that's just not fun to wake up every night. So pelvic floor PT, if there, I can't believe there's a single person in this room who hasn't been told to do Kegel exercises at some time. Have you ever actually tried to do Kegel exercises that they have been prescribed? It can be your full-time job. It is just, first of all, if you even remember to do it. And secondly, even if you were like, you made it your life mission to do Kegel exercises because of stress incontinence, you may not be doing them correctly.
Yep.
How do you know you're doing them correctly? Well, the one way you can do that is to do that with biofeedback. So if you see a pelvic floor PT, they will actually use biofeedback so that you can actually know that you're using the right muscles in the right way so that your Kegels are effective. So I'm going to make a recommendation. Erin Lamb. Have any of you ever met Erin Lamb? Got a name that's familiar? Erin Lamb was the physical therapist at Holland Hospital for quite a while. She's very open about this. She had a very rough journey a few years back with breast cancer, premenopausal breast cancer. She'd always been a pelvic floor. She'd always had pelvic floor specialty in her PT practice, but then she experienced some of these things because she had breast cancer, aromatase inhibitors, that type of thing. And she started her own practice, Equilibrium Physical Therapist. I'm putting a plug in for Erin because I know she's an excellent pelvic floor PT provider. I've had many patients who've seen her and have been really happy. She sees male patients as well for male incontinence too. But she's a good resource. I don't know what her schedule looks like. And I have to be honest with you, I have never met Erin face to face, but I've sent enough patients to her, had enough patients who've seen her that I have a lot of trust in her. Pessaries, different types. I don't know how often these are being used now, there was a time in OBGYN that I had a fair number of women, Jane's nodding her head, that used pessaries as aside from surgery or anything else, to actually hold up the vaginal or to hold up the bladder and the uterus. And you can see how how that fits in there. It just relieves the pressure on the pelvic floor and supports those organs. So it can help with the uterine prolapse and help with the bladder prolapse and restores that proper alignment. And these can be put in for months at a time. There is some risk that they can cause a fistula between tissue within the GU tract. And they are inserted by you don't do this yourself, they're inserted by typically initially by a provider. So, and there's several different types there. So this is something you'd want to talk to your GYN about. I don't think your general practice person is going to be familiar with this. And then finally,
Okay.
was there a question? Oh, okay. I thought I heard a question. I thought I heard someone say something. Urinary tract infections, signs and symptoms. So GSM can mimic urinary tract infections. And this just gets to be really complicated because older adults don't have typical. So if they do have a UTI, and maybe you've experienced this with your older relatives, that they develop some confusion, they start falling, you take them into the ER, what's the very first thing they do is a urine culture, right? Because they're worried that they have a occult, undiagnosed UTI. So that can happen, and I'm going to talk about the flip side of that in a second. So if it's not that if an older adult has a urinary tract infection, it can have some significant consequences. So we're always on this thing of deciding, is this typical GSM symptoms that have been going on, or is this UTI? And that takes some clinical judgment. Certainly, if you yourself, without the dementia, without the confusion, if it's a sudden abrupt development of these symptoms, you can probably tell that you have a UTI versus your underlying GSM symptoms, right? Vaginal estrogen has been shown to decrease the frequency of UTIs annually and lengthens the time between. And again, it's because it's restoring some of that tissue integrity related to estrogen deficiency. So I've mentioned this before in this talk, estrogen is helpful for urinary tract, and it does have some effect on decreasing UTIs. So Jane wanted me to talk about asymptomatic bacteriuria. I practice that and I'm still not good at it. So this is more of a problem in hospitals and nursing homes. So if you have relatives who are in those situations, but it may be something you would face too. About 20% of women over 80 will have bacteria in their urine and they don't have a true UTI. But we are quick to the trigger to put them on antibiotics. And with that come lots of complications, obviously, the most serious of which is Clostridium difficile, which is that bad intestinal infection that comes from overuse of antibiotics, so which is very hard to get rid of. So the real diagnosis for asymptomatic bacteria in the urine that is asymptomatic is doing clean catch urines ×2, having a lot of microbes in the urine and not having urinary tract symptoms. So, if a patient has some dementia, that's what complicates it. But if you're talking about people who are very oriented, know whether they have urinary tract infections or not, and they find themselves in this situation, they should not be put on antibiotics because this is just kind of the milieu or their normal state to have this bacteria. And we don't want to treat them for that. So this is something you may want to advocate for yourself or for other relatives. If the patient does not have symptoms and they're getting this bacteria in the urine, they should be evaluated. Are they having true symptoms? And then you have to sort that out from their GSM symptoms. and not necessarily put them on antibiotics. When I looked at the literature on this, there are huge studies going on right now, and maybe Jane, I think, was aware of this. Huge studies going on trying to get providers to stop doing this. And it's really hard to get providers to stop putting these patients on antibiotics because we're so afraid that something bad is going to happen. They're going to become septic, that they've done study after study of, ways to prevent providers from doing this, and we still do it. So just a little informed consent for you about that. Here's some resources. My go-to person for years has been Dr. Barb Dupree. She's a friend, family friend, personal friend, colleague that I work with. Unfortunately, Barb, who started women's specialty clinics at Holland Hospital, is doing a phased retirement, and she will not be working, I think, after this summer. But this is her handpicked replacement, Dr. Lauren Dreschbach, who's a DO, who has a specialty. Some people are nodding, and maybe you've met this woman. She's young. I've just heard great things about her, and I know that Barb Dupree kind of handpicked her, and they've been working together for this menopause specialty. So, website for ACOG. Dr. Dupree has a business called Middlesex MD. I don't know that she's going to keep that going, but she has a Facebook page called Middlesex MD. It's been up now for a number of years, maybe 10 years. And you can get on there and you can find all kinds of really cool information going back through the Facebook posts about menopausal health. So I recommend that to you. That's pretty, if you're on Facebook, just search Middlesex MD. I think the last time she posted was over a year ago. I don't think she's going to keep it up, but it's up there and it's worth looking at. There's the NAMS website. And then this is a TED Talk that I make all my students listen to, How Menopause Affects the Brain by Lisa Mosconi. This is if you just thought you were going crazy when you went through menopause, you need to listen to this lady because she just normalizes everything. She just tells you you're not crazy. You just don't have any estrogen in your brain. So here are my references as they are. And what questions might you have? Got 10 minutes for questions, but I'll stay here later if you have other questions. Yeah.
Since gynecological exams aren't done anymore after 65, 70, should we request them more? For example, ovarian cancer is pretty silent until it's not. And I had a friend in her 70s, late 70s, get cervical cancer. But you might not have a symptom that induced you to say to your doctor, I need to have a cervical exam.
Yeah, that's a good question. And it's unusual to develop cervical cancer in your 70s because it's often HPV, and you would think somewhere along the line they would have picked that up. Ovarian cancer, the screening for ovarian cancer with that pelvic exam is really just doing a bimanual exam and trying to feel for an enlarged ovary. It's not terribly sensitive, but it's something at least, because postmenopausal women, you shouldn't be able to feel their ovary at all. They have become shriveled little, things, sorry to say. So if you feel a mass, where the ovary is, that would be something I get an ultrasound. I think what the big organizations are saying, it's a discussion between the patient and the provider. There's a very low risk of getting hurt for the pelvic exam. It's not zero, but there's very low risk in terms of just the embarrassment of doing it. So I think if anybody had questions or they were concerned, I would encourage them to talk to their provider and have them do the exam. But it's not hugely sensitive for ovarian cancer. That's a problem with ovarian cancer. We just don't have a good way to figure that out. So, but that's a very good question. So
I would, just a comment too, I would suspect probably that if you went to a women's clinic, you'd be way more likely to end up with at least some pelvic exam.
Yeah.
I think male doctors these days, I'm finding, are just kind of reluctant to do it. They need to have someone else in the room and, I don't know, it's just gotten really awkward, it seems to
Mhm.
me, whether, whether they're personal friends or not.
Mhm.
And I just think maybe you're going to get a little different care in a women's health clinic.
I
Not to be
100%
sexist
agree.
about it, but I just think it's how it is.
I 100% agree with that.
Yeah, I've been in clinics where they don't even have speculums in internal medicine offices. If you say, I think I have something going on, oh, we need to refer you.
Mhm.
So anyway, it's really changing.
There's a question online. Um, does Dr. McKay accept patients? And if so, how does one contact you?
Well, I don't do women's health now. I only do bone health. And I am accepting new patients, and that's at Shoreline Orthopedics. So patients can refer themselves. They don't need they don't need their primary care referral. Although almost every primary care doctor in Holland refers to me for bone health. So usually they're pretty happy with that. But unfortunately, I don't do women's health anymore. So and this presentation was missing a slide, but I will, if you have a pencil and paper, I will give you my 2 email addresses if you would like to reach out to me by email. Can I do that, Jane? Can I?
You could give it to Amy and she could just distribute it to the
Okay,
group.
we'll do
too.
that.
Yeah.
So if you,
Sometimes they share the slides if you're comfortable with that.
yeah, I just don't have it on a slide.
Yeah,
That's a problem.
have
You
to
could,
add it.
you can
Yeah.
share the slides all you want to.
Okay.
I can have Amy send it out to the list of people registered. If you have a women's health problem, I'll give you my Grand Valley address, email address. If you have if you're interested in bone health or me talking to you about bone health, you can reach out to me at Shoreline Orthopedics. So I see patients there now 3 days a week. And then my other time is spent at Grand Valley. Yeah.
Do you have a clinic then? Not you personally,
Yeah.
but is there a women's health clinic at Grand Valley State? Is that what you're saying? Or no, it's more just
no, I'm giving
classes?
you my Grand Valley
Yeah, yeah,
email
okay.
so that I
I
keep
just-
track of the women's health
Okay.
questions. Yeah.
Looks like you have a question.
What do you think about bioidentical hormone replacement?
Yeah, I actually used that when I was, because that Barb Dupree prescribed that for me. I think my point here was when I was talking about just be careful that if you have a uterus, that's being done by uh, a true pharmacist and they're matching the estrogen and the progesterone because you don't want to just be on estrogen compounded bioidentical hormones and not have the progesterone. But honestly, that's what I did when I was early menopause through Barb Dupree. So I don't, and the proof is in the pudding. What are your symptoms? Is it helping the symptoms? Right. Hi, Kathy.
Does anything show up in blood tests that are not seen because we're not seen physically? Now,
Um,
I have been told when I've asked questions,
Mhm.
well, we'll know that through your blood test.
I can't, well, I mean, obviously they did a blood test for estradiol levels or whatever, they would be low, but
Right.
we don't even need a blood test to tell us that. From the ovarian cancer, point of view, they may do CA 125, but there's a lot of controversy about doing that for false positive. So anything about GSM that I've been talking about today, I can't think of a blood test that would actually be diagnostic.
I agree with you 100%. I
Yeah.
don't think blood tests can detect much down there. And they don't even recommend doing the CA 125 as a screening. There's some new technologies being developed that might detect circulating cancer cells for certain types of cancer. And they're very interested in ovarian cancer and colon cancer because they're hard to detect until it's sometimes advanced. But those aren't even ready for prime time. I mean, it might be within a few years, but I mean, if you have abnormal labs, and they're going, gosh, and then they do a scan and you have Mets or something to your liver. Well, yeah, they detected the cancer, but that's a little late. So I don't know if that's, yeah. And then I just wanted to make a comment about as a former practicing physician, I had a lot of women that would call in and say, I have another UTI, and they might get, various providers because they called at different times, maybe not spoken to me particularly, even though I was their primary care provider, and they get prescribed an antibiotic. And then they call, like a month later, and I have a UTI again, and it goes on and on. I mean, really, you shouldn't be upset if they want you to come and give a specimen, because they may be giving you antibiotics for GSM, and it's not going to help you at all to have those antibiotics. It might get better, but it might not be because you had a UTI. And that was the whole point too about the bacteria. I used to get a lot of pressure from people. Well, I have bacteria in my urine. Yeah, well, when you become menopausal, that can happen, and they're not necessarily pathogenic, which is why we do the urine culture to see if it's kind of a pure bacteria, or at least nearly pure bacteria, because then we know that's the culprit and we can target the antibiotic for that particular culprit rather than just doing shotgun antibiotic, often the same one every time you call, like macrobid over and over again, which isn't even necessarily the best one for aging women. It's a whole nother topic. But I just want you to get the right care for the right problem, which was one of the reasons I brought this up. And I really appreciate your emphasis on vaginal estrogen, because I think a lot of providers don't even think about that. I mean, well, especially my age, we were all brought up with systemic hormone therapy, which then came under fire, like narcotics are under fire now. No women could have them, no matter how much they were suffering. And yeah, it was a tough time. And then that led to some good developments in terms of the benefits of the vaginal route, which she is right, very minimal systemic absorption with most of them, not all, but that makes it a lot safer, less blood clots, less risk. And I'm so glad you brought up the thing about the product stuff, because that drives me nuts. A lot of topical medicines you get, they're just going to be like Voltaren cream, if any of you use that, on your joints, and it's got that terrible label might cause GI bleeds. No, it's not going to. It's so minusculely absorbed into your body, but they don't have a separate thing to attach to those drugs when they're topical. They just put the systemic drug profile on there. And I used to also tell my patients, if they put one of those things on a gallon of milk, you would never drink milk either. Diarrhea, bloating, oh my, high calcium levels. I mean, geez. So I don't say discount them, but do take them with a grain of salt. And
Okay, I moved here 3 years ago and lived in California under a different healthcare system. What I'm not understanding is, why is it that women's health over a certain age is being so ignored? And why, first thing
Amen.
I don't understand that. In San Diego, I had a mammogram every 2 years, and boy, was I reminded that I needed to have it. There was no doubt. I had a regular gynecologist, and yet here my primary says, oh no, we're not doing that after a certain age. No, you don't really need to have a gynecological exam, even though I have a partner and have some discomfort. And so I have pursued those avenues myself of making appointments and, go to the women's or the over Zealand Hospital to their lab, and they said, of course you need to have a mammogram every 2 years, regardless of your age. So what is it why is women's health being so downplayed, I guess? I don't understand that.
I think Jane is eager to answer that question too.
I just think we haven't used our voice.
Yeah.
Honestly, women's healthcare has been long neglected, and in terms of research, especially so. That's why there's so little studies on this, because most of the studies are most researchers are male. I mean, that's changing, but they tend to enlist male populations, and thankfully, we're seeing some push to include more women in more research studies and to focus more on women's health. And I think, not as a political plug, but Biden just recently announced in the last week that he's he's gathering a team to put a greater emphasis on women's health issues generally, women's access to health, knowledgeable information about how to treat women's health problems, because our metabolism is different than men, and yet we're treated with the same drug, same dose that were researched on male patients and not females. And maybe in California, there's just a little more progressive environment. I mean, possibly. But I just think women's health has been neglected for a long time. And it's sort of a systemic problem in how the whole structure of medicine was, and the low penetrance of females in the field for a long time. My dad was a physician, and I think he went to medical school in the 40s. I think he had 2 female classmates, and they went into dermatology or some, appropriate field for a woman to have a family. But now we see, female surgeons. So things are changing, and now medical schools are almost 50%, sometimes more than 50% female. So I think it'll get better, but we've been in a desert of healthcare for a long time, and we just didn't know it. And people are speaking up like, what? You don't need to look down there at all anymore? You gotta be kidding me.
Yeah.
But vulvar cancer is real, and it's not nice. And most of us don't have the agility to look down there real good and keep our bifocals on. Yeah, let me see.
Yeah, I so agree with that. And you pointed it out, Jane, and I agree with it. If you saw my slides, slide after slide said small studies. They don't have these big random controlled trials for any of this. That's okay. I just wanted to add that to say what you were saying. Yeah. Mhm.
Do you want to say something?
But I think what referring to your concern is that the insurance companies are not paying for these mammograms and various testing. And I've got cancer in my family, maternal, history of it. And it's kind of like, well, when you turn 70, you won't have a mammogram. You won't have, pap smears. And it's like, really? So I'm just really concerned from the insurance company perspective.
Yeah, I think you do have to Jane's point, to everyone's point, you have to advocate for yourself.
Yes.
The U.S. Preventative Services Task Force says mammograms should end at 80, not at 70. So it should be covered up to then. And then I treat 93-year-olds for their bone health, because they're viable, they're walking, they're talking, I have a hard time saying not doing a mammogram on an 80-year-old. If they said I would not pursue treatment, that would be one thing, but if they want to pursue treatment, I don't know, what do you think, Jane? I'd be like, it saddens me that we suddenly start doing.
I think actually mammograms are covered by Medicare, and according to the U.S. Task Force, annually until the age of 80.
Yeah.
And Medicare will pay for it, but
Mhm.
it has to be 366 days from your last
Yeah.
one to get it paid for. But anytime, some of this not getting paid for is coding, and doctors' fears of not getting paid because they didn't code it right. So again, going to a women's clinic, you might have less pushback about general screening. If you go, gosh, I'm having incontinence, or, almost all of us have something going on down there, hence my title. And I feel like there's something down there that doesn't belong there. Well, they can bill for that, foreign body sensation in the perineum. You just get creative with coding, or family history of cancers, ovarian cancer, cervical cancer. And most of the time then insurances will cover it, because insurers know that they're going to pay less money to get it done, caught early, than wait a long time. But if they can't figure out a reason to code it, then they may not get paid. That's just how it is. But I think, again, it's something to do with just using our voices and asking for what we need, and not being embarrassed to ask. Other questions? Guess we're running over a little bit.
Yeah.
Maybe nobody cares. We're all happy about it, right?
Regarding hormone replacement therapy, is there an age to stop taking it for anyone who started right at menopause?
Wow, that's such a good question. I'm not sure if I know what the current NAMS guidelines are. I do know about not stopping it. I think that requires a good assessment of, so the things we worry about that are, some worry about breast cancer, more worried about cardiovascular events. So I certainly wouldn't have a patient still on hormone replacement therapy if they had high cardiac risk, high stroke risk, the risk factors for that, because then I think the risks outweigh the benefits for sure. And then there's a physician in the room who may be able to answer that better. So
I think that's a bit of a moving target too, like lots of things. And actually we're accumulating a lot more evidence and data about this. One thing for sure is if you go on it in early in your life and you don't have a uterus, so you can just do estrogen, then the route matters. Estradiol patches or transdermal is safer and probably could be continued quite a bit longer, but there is a cumulative effect of any of these hormones in terms of increasing your risk for malignancies too. And I don't know that we know when the best time is to stop. I've seen 10 years. Some say longer, some say less. I think we actually don't have enough data, and a lot just depends on your personal family history. If there's breast cancer, then you probably don't want to be on it any longer than necessary. And if there's not, maybe you could do it more safely. And all of this, and you alluded to this, Anne, was it has to be based on patient goals and understanding what their goals are and what their risk level is for that treatment and their willingness to take that risk, or in other words, risk aversion. Because some women don't want estrogens at all because there's family history of breast cancer and that might be smart for them, but they might actually be able to safely use vaginal estrogens with a discussion about the relative safety. Does that make sense? Wish I had this many years and stop, you're fine. But this is the art of medicine. I tell people, we're working on the science, but there's definitely an art to it.
I'm just wondering if you agree that there's no cure for lichen sclerosis.
No, there's a lot of evidence for treating it with high dose steroids and having it by cure. Do you mean it will go away and
Go
never
away?
come back? I think you can put it in remission and long-term remission with high dose steroids, and it needs ongoing, evaluation and monitoring. But I wouldn't, if you're talking about you get a course of steroids and things look better and then we're done for the rest of our lives and we never have to think about it again. No, that's not true. But it needs ongoing monitoring. But if you're talking about there's nothing you can do to treat it and reduce your risk of it progressing, there certainly is. So does that answer your question?
Yeah, it does.
Well, I think that's it for questions, and we've run a little over, but thank you, Anne, for your nice presentation. And we'll send that information out with her email contacts. Thank you.